Okay, so let's start. Hello, everyone. Welcome to Wisonic Global Webinar. This is Charlie, International Marketing Manager from Wisonic Medical. So today we are very honored and proud to invite Professor Kessler to share with us his latest research. Before we start, let me introduce our special guest, Professor Frank Law, medical doctor. He is the Dean of Department of Anesthesiology, Foshan Hospital of Traditional Chinese Medicine. His hospital is very famous in China for its orthopedic medicine and has one of the best regional anesthesia team in China. So now let's welcome Professor Fulong Luo to give us a very brief introduction for Professor Paul Kessler. 也欢迎国内的各位老师。今天呢，因为是英文授课，所以也请大家尽量英文提问。谢谢。那我们有请罗教授来给我们介绍一下 Kessler 教授。
Okay, thank you, Charlie, and thanks Wisonic for inviting me as a guest of today's Dandelion College online lecture. It's my great honor and great pleasure to be here as a guest, really. I once was a trainee specialized in regional anesthesia in Professor Kessler's hospital about 10 years ago, I spent 3 months there. I've learned a lot from Professor Kessler. Not only the detailed skills in nerve blocks, but also the principles, protocols, and clinical rules in regional anesthesia, I think which benefited me a lot in my later clinical practice. That's wonderful memories for me in all my life, really. Thank you, dear Professor. Now I'll give a brief introduction to Professor Kessler. Professor Kessler is board certified in anesthesiology, critical care medicine, pain therapy, and emergency medicine, and was awarded professorship in anesthesia in 1998. He received his specialty training in anesthesiology at Johann Wolfgang Goethe University, Frankfurt, Germany. Since February 2020, Professor Kessler is vice chairman of the Clinic of Anesthesiology, Intensive Care Medicine, and Pain Therapy of the University Hospital Frankfurt. His clinical expertise focuses on regional anesthesia. He was co-authored over 100 peer-reviewed papers, review articles, case reports, and book chapters. Paul Kessler is a member of many national and international societies of anesthesia. From 2009 to 2014, he was chairman of the German Task Force of Regional Anesthesia. From 2009 to 2013, he was board member of the ISRA, and from 2014 to 2018, he was a German zone representative in ISRA Council. He is currently the chair of the ISRA Cadaver Workshops. He will give us a wonderful lecture later. The topic is significance of the new truncal blocks in regional anesthesia, a wonderful topic for all the anesthesiologists. Thank you, Mr. Kessler. Okay, now let's welcome dear Professor Paul Kessler.
Let's welcome.
Thank you very much. Thank you very much for the nice introduction.
Okay.
Now we'll begin our lecture.
Hello and good afternoon in Europe, good evening and good morning somewhere else in the world. My name is Paul Kessler. I'm member of the Clinic of Anesthesiology, Intensive Care Medicine and Pain Therapy at the University Hospital in Frankfurt, Germany. The topic I'm going to talk about today is significance of the new truncal blocks in regional anesthesia. This slide shows you some of the most common truncal blocks. In the thoracic area, these are the paravertebral block, intercostal block, Pecs blocks, the serratus anterior plane block, Erector spinae plane block, retrolaminar block, or the thoracolumbar interfacial plane blocks. And below you can see the first description of the block. In the abdominal area, we have transversus abdominis plane block, block, ilioinguinal, iliohypogastric block, fascia iliaca block, quadratus lumborum blocks, and the Erector spinae plane block also. I will focus in my presentation today on the Pecs block, serratus anterior plane block, Erector spinae plane block, and quadratus lumborum block. Here you can see how often these blocks are found in the PubMed when you look at these blocks. And you can see the TAP block is one of the oldest blocks. First description came nearly in 2006, and you can see up to now we have nearly 1,000 publications of the TAP block. But you can also see that the newest one is the ESP block. First description comes from autumn 2016, and up to now we have nearly 500 publications on the ESP blocks. What is common to all these blocks is that these are interfacial plane blocks. These are no classical nerve blocks, though you don't need a nerve stimulator to do these blocks. You can do it in the awake or anesthetized patient. Most of the blocks are analgesic blocks and no anesthetic blocks. And what is also common to all these blocks, these are inconsistent in their success rate, and they have a low complication rate. We also have to constatate that for many of these blocks, we only have case reports or case studies, and only for a few ones we have randomized controlled studies or systemic reviews. These are no nerve blocks in the classical sense, and for most of them, nearly the ultrasound technique is the method of choice when you do these kind of blocks. Here you can see a cross-sectional through, and you can see where the probe is placed when you do the blocks. For the rectus sheath block, on the left side, the probe is placed just anteriorly. For the Pecs or the TAP block, the probe is placed in the flank, and for some others, as the QLB or the ESP block, the probe is placed more closer to the midline. This here shows you how the block works. The target of these blocks are the thoracoabdominal spinal nerves. And the one part of the spinal nerve is the ventral ramus with the lateral cutaneous branches for the lateral side and the anterior cutaneous branches which innervates the anterior part of the trunk. And we have the dorsal ramus which innervates the muscle of the back and the skin of the back. And in addition, we have the sympathetic trunk, which communicates with the rami communicants with the spinal nerve. To understand what these blocks can do, it's important to know where you place your local anesthetics. Here you can see the spinal cord, you see the dorsal root and the ventral root, which form the spinal nerves, and you can see the sympathetic fibers from the visceral organs which communicate with the spinal nerves, and the spinal nerves end in the ventral ramus and the dorsal rami. If you place local anesthetics lateral from this line, so you will produce only a somatic analgesia. That means that you have an analgesia for skin, muscle, bones, and the parietal pleura and peritoneum. This can be achieved by the intercostal block, TAP blocks, Pecs, rectus sheath block, ilioinguinal, Erector spinae, and quadratus lumborum blocks. When you do these blocks, you will have an opioid-sparing effect, so these are only analgesic blocks. But if you place local anesthetics medial from this line, you will produce a somatic and visceral analgesia. That means, in addition to the former one, you will also have analgesia for the visceral pleura and peritoneum and the visceral organs. So This can be achieved by the spinals or thoracic epidural, by the paravertebral block. But what about erector spinae plane block and the quadratus lumborum block? If you have a somatic and visceral analgesia, you will have an opiate-free patient after the operation. But these blocks can also be used for a surgical anesthesia. You can do thoracic and abdominal operations without general anesthesia when you use only these kind of. So let me start with the Pecs blocks, which are blocks for breast and chest wall surgery. We have three different kind of blocks: Pecs 1, Pecs 2, and serratus anterior plane. All these blocks are first described by Rafael Blanco, Pecs 1 in 2011, Pecs 2 in 2012, Pecs 3 or serratus anterior plane block in 2000. Here you can see the innervation of the female breast. Important are that included are fibers from the cervical plexus, the supraclavicular nerves, from the brachial plexus, the lateral and the medial pectoral nerves, and the nerves from the branches from the spinal nerves, the lateral and the medial branches from the thoracic intercostal. This shows you what is important to know from the anatomical side when you do Pecs block. You can see here the pec major muscle, pec minor muscle, the serratus anterior muscle, and you can see the long thoracic nerve and the lateral cutaneous branches and the medial cutaneous branches of the spinal nerves. For the Pecs 1, you have to place a probe, the linear probe, just below the clavicle. For the Pecs 2 blocks, you move the probe more distally at the level of the fourth rib, and the serratus anterior plane block is done at the level of the fifth rib in the mid-axillary line. The Pecs 1 block will block the medial and the lateral pectoral nerves. The Pec 1 blocks has no skin innervation. Indications are plastic breast surgery, port implantation. Here you can see another anatomical view of the lateral and the medial pectoral nerve, and the probe is placed just below the clavicle. Here you can see the ultrasound picture of a Pecs 1 block. You see the pec major muscle, pec minor muscle below the axillary artery and the vein, and the needle is advanced, in this case, from lateral to medial. And the end of the tip is placed in the plane between the major and minor Pecs muscle. Here in this video, you can see how the local anesthetic is spreading in the interfacial plane between the Pecs major and minor muscle. Easily to identify is the pectoral branch of the thoracoacromial artery, which lies in the same plane as the pectoral nerves. The next one is the Pecs 2 block. With this block, you will block the lateral cutaneous branches of the intercostal nerves T2 to 6, the long thoracic nerve, which innervates the serratus anterior muscle, and indications are, together with the Pecs 1 block, tumor resection of the breast or mastectomy. Here you see the anatomical picture. For the Pecs 2 block, the probe is moved more caudally at the level of the fourth rib. This picture shows you the relevant zonal anatomy of a Pecs 2 block. The local anesthetics is placed above as a Pec 1 block and below the Pec minor muscle. And the puncture comes from medial to lateral or from lateral to medial. The needle is advanced from medial to lateral. The first injection point is below the Pec minor muscle. Now the local anesthetic is injected in the plane between minor and serratus anterior muscle. The needle is retracted between the minor and major muscle, and this is a so-called PEC 1 block. The last one of the PECs block is the serratus anterior plane block. With this block, you will block the intercostal nerves T2 to 9, long thoracic nerves, the thoracodorsal nerve, which innervates the latissimus dorsi muscle, and the intercostal brachialis nerve. Indications for these blocks are, for example, major breast surgery or lateral thoracic wall surgeries. Here, the relevant anatomy. The probe can be placed in the longitudinal position in the mid-axillary line at the level of the fifth rib, or, what I prefer, in the transverse position in the mid-axillary line. With this position, it's easy to identify the origin of the latissimus dorsi when you move the probe posteriorly. There are two options to perform the serratus anterior plane block. First, you can do a superficial block when the local anesthetic is placed above the serratus anterior muscle, or you can do a deep serratus anterior plane block when the local anesthetic is placed below, or you can do a combination of superficial and deep. The question is, which blocks is more sufficient, superficial or a superficial injection or a deep injection? There are no clear data showing that one block is better than the other ones. In this publication from Biracha, he could show that the deep injection below the serratus anterior was more sufficient. Here you can see a scheme how the block is done. You see the latissimus dorsi muscle, the serratus anterior muscle. You can identify the ribs. You see the pleura, and you see the position of the needle for the superficial. Here, the needle is advanced for a superficial block. You see the latissimus dorsi is lifted up, and you can see on the left side, I show you again, on the left side you can see the thoracodorsal artery. After finishing this, you can do a deep SIP block. You can see here how the serratus anterior is lifted up of the sixth rib. What is the evidence for the PECs blocks? This picture shows you a meta-analysis. PECs 2 blocks versus IV opioids for breast cancer surgery, and you can see that the oral morphine consumption is lower for the PECs blocks compared to the systemic analgesia. Comparing the pain scores of the PECs 2 block with systemic opioids, the pain scores were lower during the first 24 hours at different time points for the PECs 2 blocks. In this study, the serratus anterior plane block was compared with IV opioids in patients undergoing thoracoscopic surgery, and the authors could find that also the worst pain was lower in patients receiving serratus anterior plane block, and also this patients were highly satisfied with the serratus anterior plane block compared to IV opioids. And another study showing also that the serratus anterior plane block was very effective as an analgesic after thoracic surgery. Here, this SAP block was compared to standard IV opioids, and also the pain scores and the morphine consumption were lower in the SAP group. Comparing PECs 2 with Erector spinae plane block for radical mastectomy, the authors could demonstrate that for the PECs block, the duration of analgesia and the morphine requirement in the first 24 hours was lower, and also the pain scores were postoperatively lower for most time points for the Pecs block. And the conclusion was that the Pecs 2 was more effective than the Erector spinae pain block in terms of postoperative analgesia after radical mastectomy. And this is not surprising, because with the Pecs blocks, you also block not only the lateral cutaneous branches of the spinal nerves, but also the pectoral nerves of the brachial plexus, which is not the case when you do an Erector spinae blade. Comparing the SAP block with the paravertebral block, where the systemic opioids for video-assisted thoracoscopic surgery, you can demonstrate that the paravertebral block and serratus block are equivalent regarding the morphine consumption, and that both blocks are better in pain scores compared to IV opioids. So there was no difference in this study between the paravertebral block and the serratus. And finally, in this study, where the serratus anterior plane block was compared with a thoracic epidural analgesia for thoracotomy pain, it could be demonstrated that the hemodynamic profile was more stable in the serratus anterior plane block. These are the rounded circles, and the pain scores are similar for both groups. So the conclusion from the study was that the serratus anterior pain block was safe and effective in treating thoracotomy pain. What are the indications for the Pecs and serratus blocks? For the Pecs unblocks, these are minor breast surgeries or pacemaker or port implantation. For Pecs 2 blocks, it's more invasive breast surgeries, radical mastectomy, and for the serratus plane blocks, major breast surgery, axillary lymphadenectomy, pectum excavatum, or the so-called NAS procedure, or thoracotomy, or rib fractures. What are the clinical applications and the conclusion for the practice? The mode of action of all these blocks is very clear and understandable. We already have some randomized controlled trials showing the effectiveness of these blocks. You can use ropivacaine in a dose, in a concentration of 0.2 or 0.5%, or you can use bupivacaine. For Pecs 1, you should use 10 ml of local anesthetic, Pecs 2, 20 ml, and for the serratus anterior plane block, 20 to 40 ml. If you perform bilateral blocks, you should not exceed the recommended maximum dose of local anesthetics. Otherwise, less can be a problem. Catheter insertion is possible. If you insert catheter, you can use a continuous rate of infusion of 0.2% of ropivacaine and 5 ml per hour. Probably a continuous infusion is not so effective as an intermittent bolus. This applies for all kinds of truncal blocks. An intermittent bolus or intermittent injection of a higher bolus of local anesthetics is probably more effective and as a continuous infusion or a patient-controlled infusion mode. The block is very effective. We have comparative studies with thoracic epidurals and paravertebral blocks, and the complication rate is rather. Complications are allergic injections, intravascular injections, last if you do a bilateral block. Nerve injury is rare because in the plane where you inject the local anesthetics are the long thoracic or the thoracodorsal nerves. Vessel puncture should be also very rare because you should know where your tip of the needle is, and then you should avoid any kind of vessel puncture. And also pleural puncture or pneumothorax are very rare complications. The next topic is the erector spinae plane block. You can see here the erector spinae muscle, and this is not one muscle. The erector spinae muscle consists at least of 3 major muscle bellies: medial the spinalis, in the middle the longissimus, and laterally the iliocostalis lumborum muscle. from the outside to the inside, we can find below the skin, that you can see on the left-hand side, the latissimus dorsi and the trapezius muscle. Below these muscles, you can find the rhomboid major muscle, and below the rhomboid major muscle, there lies the erector spinae muscle, which can be seen on the right-hand side. This is the first description of the erector spinae plane muscles from 2016 from Mauricio Ferrero from the Kijijin group. And this were two case reports of a patient with neuropathic pain after rib fractures and rib metastasis. And the erector spinae block was done at a level of T5 and 20 ml of bupivacaine, 0.22% was injected, and they found a spread posteriorly and anterolaterally between 2.3 to 2. And they also found that the contrast dye could be shown in the area of the spinal nerves here at this level, and this would explain the covering of the anterolateral parts of the chest. We know now that we can do an erector spinae plane block not only in the thoracic area at a level of T5. The ESP block can be done higher at the level of C7, T1, and at the level lower T1 and in the lumbar spine area. So this block seems to cover everything. It's a so-called all-rounder among the truncal blocks. You can use it for analgesia after thoracic surgery and abdominal surgery and upper limb surgery. Depending where you do your block, you can cover an area starting from the cervical to the lumbar area. This picture shows you how the ESP block is done. You see here the dorsal ramus of the spinal nerve. On the left side, you can see it in the cross-sectional view. We use routinely a linear probe, which is placed paramedian in the longitudinal position, and the needle is advanced from cranial to caudal with the tip direction of the transverse process, and then local anesthetic is injected. You can do it with a patient in the lateral, sitting, or prone position. On the right side, you see here the ultrasound picture. And here you can see the video. You see the trapezius muscle, erector spinae muscle, the transverse process. The needle is advanced to the transverse process. And when you are in the correct plane, you can see the erector spinae is lifted off the transverse process. Catheter insertion is also very easy because you advance the catheter in plane and the insertion can be followed up very nicely with the ultrasound. The question is, how does the erector spinae block work? Here you can see a cross-sectional view. You see the erector spinae muscle, you see the dorsal ramus with a medial lateral branch. You see the ventral ramus, you see the sympathetic trunk, and you see the advancement of the needle to the transverse process in the local anesthetics is always blocking the dorsal ramus of the spinal nerve. The question is local anesthetic flowing into the intercostal space or the paravertebral space or the epidural space and producing by this complete somatic and visceral analgesia. Many cadaver studies were done to answer this question. This is one showing that when you look for the cadavers, the ventral rami are not stained with contrast dye. Only the dorsal ramus here on the right side in the picture are stained with contrast dye. So the conclusion was there was no spread of dye anteriorly to the